which is part of our University Round series, the last one of this calendar year. And we have some special messages ahead for you. First of all, I'd like to just remind you of our holiday party, which is coming up next week on Tuesday. It's at Constantine Restaurant again. And many people have been asking, the candy bar will be back. For every child 12 and under, we're making a donation to the Daily Bread Food Bank. So I would like to encourage you to come on out, bring your family. If you haven't registered yet, the formal registration is closed, but that's okay. Just come on the evening. We have plenty of food and drink and fun in store for you. So welcome also to those of you who are online. I hope you'll stay and maybe ask some questions at the end. There should be a good discussion. And I want to, first of all, just welcome the members of Robin's family who are here. Robin McLeod was an icon, not only in colorectal surgery and surgical leadership, but also in evidence-based quality improvement. And that's the theme of this particular rounds today. Our lecturer is David Barron, who'll be introduced shortly. I also want to begin by saying that we acknowledge that the land upon which the University of Toronto operates and on which we're meeting today was for thousands of years the homeland of many different Indigenous peoples, including the Haudenosaunee, the Huron-Wendat, the Mississaugas of the Credit, and the Anishinaabeg. And it is now still home to many diverse peoples across Turtle Island. We recognize the historic injustice done to the First Nations, Métis, and Inuit peoples, and we seek to do better in our relationships with them and with the land in the future. So with that, I'm going to call up Aaron Kennedy. Aaron Kennedy, who's the head of the Division of General Surgery at Mount Sinai Hospital, was a student, resident, fellow, colleague, and friend of Robin's, and she will say a few words about Robin.
Good morning, and thank you, Carol, for this opportunity for us to remember and to honor Robin today. As you just said, I've known Robin as a medical student, a surgery resident, a fellow, PhD student, and a colleague and a friend for over 30 years. And over the course of Robin's career, she really did change the culture of surgery at the University of Toronto and across Canada and around the world by ensuring that surgical care was based on strong scientific evidence so that we would achieve the best outcomes for our patients. She was one of the first surgeons in Canada to perform randomized control trials, to obtain quality evidence and teach residents to critically appraise the evidence. She established the best practice in surgery. And just so all the residents now know, when I was a resident, there was no best practice in surgery. So she was the one that introduced all of that. And she led multidisciplinary teams to create treatment guidelines for all of us to ensure that we're providing the best care possible to our patients. Her commitment to research and evidence-based surgery has led the University of Toronto in being the second-ranked research university for productivity and the fourth best university in surgery in North America. Robin was a master surgeon who touched and shaped and saved the lives of thousands of people throughout her career. She was a trusted colleague, mentor, and friend who made us all better surgeons and human beings. And collectively, her legacy will live on in all of us. While it is with deep sadness to acknowledge today marks the first Robin McLeod lecture without her, it makes me smile to know that her spirit will be looking down on all of us to make sure that we do a good job and kick our butts if we don't. And I'm also very honored to have her family here. John is here today, and also at our dinner last evening we were able to have Stephanie and Claire and Kathy. It was very nice to have your family share this event with us today. Thank you. And in closing, I'd just like to say that one of Robin's friends, Sandy, shared a quote with me from Kavita Ramdas, who's the CEO of the Global Fund of Women. And this is really the way that I've wanted to remember Robin. And this is the quote: "We need women who are so strong they can be gentle, so educated they can be humble, so fierce they can be compassionate, so passionate they can be rational, and so disciplined they can be free." Thank you.
Thank you so much, Erin. And now to tell us a bit about our speaker, who is in a way a guest because he's leaving Toronto. I'm going to invite Charles Demestral to come up. And Charles is a vascular surgeon and surgical scientist at St. Michael's Hospital, and he's the organizer of the Robin McLeod Lecture. So Charles will tell us about David. Thanks, Charles.
Thank you. Well, it's my pleasure to introduce Dr. David Barron. Dr. Barron came to Sick Kids Hospital as the head of the Division of Cardiovascular Surgery in 2019. And prior to that, he was a senior cardiac surgeon at Birmingham Children's Hospital in the United Kingdom since 1999 and a professor of surgery at the University of Birmingham. He graduated from St. Thomas's Hospital in London and has his cardiothoracic training at Papsworth Hospital, the Royal Brompton Hospital, and Great Ormond Street in London. During his residency, he obtained an MD from Imperial College in biomechanical cardiac assist and is dual qualified in both internal medicine and cardiac surgery, or cardiothoracic surgery, pardon me. He was the lead of the congenital cardiac training in the United Kingdom and has been on the executive of the British and European Cardiothoracic Societies, as well as on the organizing committee of the American Association of Thoracic Surgery. His major research interests include hypoplastic left heart syndrome, congenitally corrected transposition, 3D printing and cardiac surgery, and complex pulmonary atresia. Dr. Barron's research is focused on surgical innovations in these conditions, as well as developing risk adjustment scores, national database development in congenital cardiac surgery, and in quality improvement systems, which ties in nicely to the legacy of Dr. McLeod, as you've heard. I would say one telling point about Dr. Barron is that when we sent him a draft of his bio, he actually took out everything about himself and then replaced it with some stats about his team. And so the cardiovascular division at Sick Kids currently provides one of the largest volumes of programs in North America, and since 1999 has operated on over 3,500 children, generated 240 plus peer-reviewed publications, gotten over $35 million in grant awards, and presented 190 plus national or international invited lectures. So it's a great pleasure that we welcome Dr. Barron up for this lecture today. And sadly, as you've heard, will be leaving us early next year to take up a position as chief of the new amalgamation of the Royal Brompton and Evelina Children's Hospital in London. So welcome.
Thank you, Charles, and thank you so much, Carol, for the invitation. I feel very honoured to be here, and I really want to say thank you to you all here at the university, and but also for the honour of giving the McLeod lecture, and kindly say with the generosity, we had a lovely dinner last night and able to meet some of Robin's family, and Robin's husband, who I know is here today. So it's a great privilege, and we're talking about, I hope I can use, as I say, some of Robin's influence and interest in the importance of using evidence-based practice and using data to drive what we do, and about how we use it in both quality assurance and quality improvement. So I'm very much aware that I'm talking about children's heart surgery, and I'm talking to a very broad audience across maybe all specialties within surgery and outside of surgery as well. So I want to perhaps share with you some of the history of heart surgery in children today, but then very much look with a kind of a lens on using data to drive outcomes. It's very much part in the world of cardiac surgery, both in children and in adults, using data and outcome reporting is very much part of our daily lives these days. And then I want to perhaps take the opportunity to share some of the amazing things that are going on and that have been going on in the last few years within our research program at Sick Kids and at Toronto General. That was Robin McLeod, and as you've heard, she had some fantastic contributions, and in her citation that when she received the Order of Canada, it was clear that she had a profound influence on medical practice and knowledge translation in surgical education and care. And I hope perhaps we can talk about some of that today. I want to try and put all your heads in the space of children's heart surgery. It's one of the commonest congenital conditions. So the heart is one of the commonest organs to be affected by congenital abnormalities, and it was, in the pre-surgical era, it carried a terrible prognosis, and less than 20% of those children born with congenital heart disease would survive into adulthood. Sorry, the format's changed slightly as it's been transferred, but remember that cardiopulmonary bypass, which is now kind of a routine, it only really became usable really in the mid to late 1960s, and so in my lifetime, the management for heart conditions and the use of heart surgery has completely changed. And in respect of that, Toronto has had a very important place in the development of cardiac surgery, and many great landmarks are thanks to people and innovations in Toronto. And Wilfred Bigelow, surgeon at University of Toronto, was one of the first people to really understand the role and the value of hypothermia, which is something that we use every day in cardiac surgery, in protecting the brain and protecting the vital organs from the insults of cardiovascular injury. And in the early days of cardiac surgery, but really before bypass was available, it was realized you could actually use deep hypothermia to protect the body, in the same concept of the child who falls into a freezing cold lake can be resuscitated and survive without brain injury. The same was done in the early days of cardiac surgery, partly due to the work of Wilfred Bigelow. And I still remember, I've spoken to patients when I was a resident who remembered as a child being put in the ice bath as they were put to sleep for their anaesthetic, and the surgery was done under inflow occlusion, no bypass, and the heart was just clamped. The surgery was done very quickly, and then you were rewarmed gradually. Things have moved on since then. Another great landmark is Bill Mustard. Bill Mustard, who was a general surgeon originally in the 1950s in Toronto, one of the real founding fathers of cardiac surgery and the use of cardiopulmonary bypass. He was the first chief of cardiac surgery here in Toronto, and from 1957 to 1976 was the chief. And in that period, we were maybe doing 75 to 100 bypasses by the end of his time here. Almost all of that was being done in much older children. But by the end of the sort of 1970s, that survival for congenital heart disease had changed to around 2/3 of those children born with congenital heart disease would survive into adulthood. And Bill Mustard had a cardiac procedure named for him, which revolutionized the management of babies born with transposition of the great arteries. He also had an orthopedic procedure named after him in the management of children with polio, and that was where surgery was, where the era of the true general surgeons, and how much things have changed in our lifetimes and how specialized we've all become. This was some of the equipment. You see that was the original bubble oxygenators that were being used in some of the very first bypass cases in the 1960s. That really took up almost an entire room just as the oxygenator component of the bypass circuit. And on the right there, you can see not only the oxygenator, but the entire pump, reservoir, and the oxygenator itself. These hollow fiber oxygenators now, are disposable and a few inches in length, and have replaced where we were in the 1960s. Outcomes since the 1980s have got better and better. And seeing some of these sort of outcomes here for national data in Sweden, that really things just got better and better in terms of the survival probability for all children having heart surgery. And if you take an example, tetralogy of fallow, I'm sure you all remember it, but I'm trying to sort of get us all in the picture to understand about where heart surgery has taken us these days. In the 1980s, almost all children with tetralogy, so remember it's a condition where you've got obstruction to the blood flow to the lungs and a VSD, a hole in the heart. But most of those children had some sort of shunt procedure or something done before they had their repair. These days, 95% of children with tetralogy are repaired in a one-off primary procedure that's done during infancy. And you can see there how the outcomes and the survival has changed for tetralogy of fallow over the decades. And the Toronto outcomes there shown. So now that pretty much we expect, more than 95% of the patients now survive, not to survive childhood, but to survive into adulthood. And now we're beginning to see a whole population of adults who've had these lesions repaired, who of course come up now with new problems that need to be faced. And we're now seeing prepared tetralogy of fallow in their 70s that may need further surgery. So we become victims of our success, but it shows that the specialty is constantly moving on. And these are two lovely examples of perhaps describe how things have changed, say over the last 100 years. Dick Kett, a Dutch painter, had tetralogy of fallow. He was one of the lucky ones in that he had a kind of balanced type of lesion where he wasn't so blue, so cyanosed, that he died during childhood. But he was cyanosed, and if you can see from his fingers, he had clubbing and was cyanosed when he painted his old self-portrait. And I say he was one of the lucky ones. He died at the age of 37, where there was no treatment for tetralogy of fallow in his time. On the right is Sean White, 3 times Olympic gold medalist, who was a repair tetralogy of fallow, and has been a great sort of advocate for encouraging development and research in heart surgery. So from all that I've told you from the past, heart surgery now in 2024, there's been a dramatic shift over the last 20 years or so towards neonatal surgery, towards infant surgery, and towards primary single-stage correction of lesions. So nowadays, a third of what we do is neonatal cardiac surgery. I'm sorry, some of these, I'm not sure if the AV people can help us, but you can see for some reason we seem to have gone through a 90-degree twist. But 30% of what we do is done in neonates. Another third, more than a third, is done in infancy. So the whole spectrum has changed into what we do. So the vast majority of what we do is kind of small baby surgery. And to have gone from those days where only 20% of children would survive to adulthood, nowadays 96% of children born with congenital heart disease will survive into adulthood. And really, for the first time, there are more adults now with congenital heart disease than there are children. And that's the first time really in human history that that's been the case. So one more thing, then another kind of, I think to try and get across the idea of neonatal cardiac surgery, transposition of the great arteries, a lethal condition where the great arteries are the wrong way around. So the blue blood is constantly recirculated around the systemic circulation, has been transformed by the arterial switch procedure, where you switch the arteries around and correct the anatomy. And the most difficult part of that surgery is the coronary arteries, which of course arise from the wrong side of the heart. The coronary arteries have to be moved across as well. And I think this arterial switch is a good example. So I promise you I'm not going to bore you with a load of operative videos, but just one very, very short couple of video clips, just to say, if you haven't thought much about cardiac surgery, or if you haven't thought about what cardiac surgery must be like in a baby, then these are perhaps some nice, very quick sort of examples. So you can see here the magic of cardiopulmonary bypass. The circulation is being supported by the bypass circuit. The heart has stopped, so you can actually operate on the heart. And you can see here, as you look inside the neonate's aorta, you can see the coronary ostium there. It's about 1 millimeter in size. So the key parts of that surgery are taking those coronaries out on a sort of little button of tissue, freeing them up, turning them around and reimplanting them into what's going to become their new aorta, because you're switching the arteries around. And I just wanted to kind of show this to give you a kind of feel for what goes on. It's, it's a technically very challenging field of surgery. There's nowhere to hide. It's high risk surgery. If you get one thing wrong, the baby won't survive. And so it really requires an awful amount of investment in all the bypass technology, in the diagnostic technology, and in the surgery itself, of course. And we're so grateful for the whole teams of perfusionists, scrub nurses, anaesthetists, intensive care specialists who help make the whole journey possible for these children. And you can see there little coronary arteries, and then those coronary arteries you can see here are now going to be reimplanted into the new aorta. Let me move on. And the arterial switch, having been only really conceived in the 1980s, these are the sort of survival for the arterial switch at the Hospital for Sick Children. And you can see really since the 1990s, the operative survival for these children is now 99%. Of all going through these very complex neonatal procedures, and essentially it corrects those children to a normal life, to a normal circulation. So it's hugely rewarding surgery. So let's turn to talk about surgical outcomes and performance. That's really the meat of what we're talking about today. And in the last sort of 5 years at Sick Kids, to say we've operated on over 3,500 children. And you can kind of break those down and try and hone down into what we call kind of index cases, which are all clearly defined conditions and procedures. So we're doing about 600 cases a year. And the overall operative mortality, which includes both 30-day mortality and any mortality within hospital, is 2.3%. So that feels pretty good. And we're, of course, enormously proud of what we achieve at Sick Kids. But the question for us all, of course, is that good? How do we know it's good? How do we assure ourselves, assure you, and assure the public that we're doing a good job? Well, the first thing you can do is you can compare it to how we've been doing in the recent past. And it seems like we're gradually showing a steady improvement in what we can do. But to really understand it, how do we kind of start to break it down? Do we break it down into individual lesions? Do we look at neonates and infants and children and see how we're doing? Or do we just pick out maybe some benchmark procedures that are kind of, we can standardize and see how we compare to other people? But this very important concept of risk adjustment, because it's not fair to just judge every single case on it without recognizing that some cases carry more risks than others. As Charles mentioned, the Sick Kids is one of the larger programs in North America, one of the larger programs in the world, and our caseload of around 575 cases here. If you see all the hospitals there in North America sort of lined up, you can see where we're usually, we're in the sort of 5 or 6 largest programs in North America. And I say you can look at, so you could just pick out some kind of key benchmark lesions, so things that are relatively commonly performed and well recognized and standardized sort of conditions, like the arterial switch I just mentioned, each sort of going from more straightforward things like an atrial septal defect down to more complex ones, and look at how you're performing with those. You can see that it certainly would seem really the index mortality for those sort of procedures these days is really extremely low. But what you really want is a benchmark. How are we doing compared to everybody else? This is really what we have now. So you have, this is the Society for Thoracic Surgeons, which is the sort of big American professional association. And really every North American centre, certainly everyone in the US, most of the Canadian centres now contribute all of their outcomes to the society. So they accumulate this huge data reserve of outcomes for cardiac surgery, and they will analyze it all, put it all together, and give you the overall figures across the whole of North America, and they'll give you your own institution's figures as well. So you can look at how you're performing against a benchmark. And this is one of the sort of fundamental, simple ways to try and assure yourself, how are we performing? How do we compare to everybody else? And you look again, you know, compared, as you see, to the benchmarks, and can be reassured that you know you're delivering at a high quality. And this is the Society's database. Really began, you know, more than 20 years ago now, and pretty well every centre in the US now contributes their data to it. And it's interesting, it's never been mandated, but it's become so profoundly used across the profession that it's very difficult not to give your data. People want to know why you're not submitting your data to them if you don't. But they've got, you know, almost, you know, 500,000 cases now in their data bank. And of course, the more data you generate, the more useful that can do in terms of analysis. And they do use benchmark procedures, as I've shown already, because that's quite a useful way to compare. They're reasonably commonly performed procedures you can compare across different programs. But they also have like a risk adjustment system, so that they've spent a long time, you know, grouping conditions and lesions and procedures into various levels of complexity that carry different levels of risk, so that you compare each level of risk with each other. And again, so this is the sort of outputs that we get fed back to us from the Society of Thoracic Surgery every year. And you can look at your own sort of index mortality against what the sort of national benchmark is, and it looks at your entire practice, you know, within the context of the risk spread of your own patients. So you get a sort of risk-adjusted expected outcomes. And I think where we've been particularly proud is in the highest risk cases, which is called Stat 5, which are really complex neonatal cases that you know carry a potentially very high operative mortality, but we're kind of below 50% below what would be expected in the North American mean, and it's quite unusual to get to that sort of level. So we're particularly proud of that. And this is another way, it's got a nice graphical way of demonstrating this. So again, if you're trying to communicate sort of outcome performance in a more general audience, then these sort of visual displays are quite helpful too. So it shows really the dark bars of the sort of 95% and then 99% confidence intervals for expected mortality within each of the different stat groups, the different risk adjusted groups. And the sort of black lines are where sick kids is, and the red dotted lines are the sort of STS, the North American mean expected performance. You can see how you're performing according to what the North American sort of benchmark standards are. So it's a helpful way of reassuring yourselves that you're aware your performance is, but also being able to demonstrate to others, whether it's your patients, their families, your colleagues, the hospital, your institution, the Ministry of Health. You can show here you've got benchmark data to help you. And again, that's sort of Norwood surgery. So the Norwood is the name given to one of the most complex procedures that we do in neonatal congenital heart surgery for babies born with hyperplastic left heart, so with really no useful left ventricle. And it's notoriously one of the sort of most high risk conditions. It's often held up as a benchmark of how a sort of high performing program is doing, and these have been our results over the last 5 years. So we've been very proud of how well we've been able to manage these complex cases, and it comes, as I say, with a whole team of people being able to deliver those sort of outcomes. So let me talk about about outcome reporting in a bit more detail. Coming from the UK, this is where the story started in the late 1990s. Yeah? And this scandal rocked the whole country, and it had ramifications across all of medicine in the UK, and I think it's had ramifications around the world in how we report our outcomes and are more transparent about what goes on in terms of surgery. And this was children's heart surgery that sparked this whole thing off, and this was in the Bristol Heart Unit, where they had a long run of really poor performance, and the concern was that the kind of results were being kind of hidden and not really addressed nor kind of opened up, and it was all hugely well-intentioned people, really decent people, but they hadn't recognized that they were falling foul of where they should have been in terms of performance. And there was a demand at the end of it really for public reporting of outcomes, for greater transparency and regulation of what was going on within the health service. And that's Sir Ian Kennedy, who led the inquiry, and the Kennedy report did not mess around with the language that was used, and it said there was a kind of old boys culture and a lack of accountability across all of surgery. It wasn't limiting the kind of review and the comments to what was happening in children's heart surgery or in heart surgery at all, but it changed things for good. Both in the UK, but I think really had ramifications around the world, that we couldn't keep behaving in this sort of way without clear accountability, and that really people recognizing that as surgeons and as clinicians, we had an ethical and professional responsibility to be open and transparent in what we were doing, that you couldn't really practice surgery without proper governance and accountability. And so I suppose, when we talk about it now, you're thinking about, what your patient might want to know about what your performance is, what your hospital administration might be up to know, but also, what the ministry might want to know about how you're performing. And all of this data now that's become routine to us is something which is kind of second nature to us within cardiac surgery. And I'm sure it's the same to in many other specialties, but I think in cardiac particularly, we have become really kind of very much obsessed with outcome data. It's difficult to get away from it, and it comes with benefits, but also with problems as well. But certainly it tells us how we're performing. It tells you where there may be gaps in your practice, and where you want to might focus signs for improvement. It gives you the opportunity to learn from the higher achievers, so you can see, well, if this institution is doing really well in this area, let's learn from them and see what we can do better. If outcome reporting is done well, it can provide us with tools for our learning, and also there are opportunities for research, of course. And Edward Denning was a famous economist, and as he said, without data, you're just another person with an opinion. But I think the kind of the real four pillars on the value of outcome reporting, of course, it gives us that quality assurance, but it gives you the opportunity for quality improvement. So the trick is trying to use the data positively to really help drive quality improvement, and find areas of your practice where maybe you're underperforming, and where you can invest to improve things. To some extent, it gives patient choice. I think it's less of an issue perhaps within Canada, just because of our geographical constrictions really, and the size of the country. But certainly within the UK, when all this data outcome reporting came, the idea was that patients would have a free choice if they chose to choose one different unit to another to go to. And of course, it does help identify poor performance, but then of course that does raise the issues around poor performance. Is then what do you do about it? Who's going to regulate it? What are you going to do with it? How are you going to manage it? So be careful what you wish for. Again, apologies for the formatting. It's changed on this PC. And this is how some of the data would be reported in the UK. It's called NICOR, the National Institute for Cardiovascular Outcomes and Research. And it would produce these funnel plots. That these are publicly available on a website. And in the UK, it became mandatory that you had to report all your outcomes in cardiac surgery to this national database. There was no choice about it. And these were published at a national portal, and a lot of thought went into how to publish them in a professional and sensitive way that recognized, some some degree of risk adjustment. But the idea is once you'd accumulated data, you would publish an amalgamation of 3 years of data at one time. So it was a constantly moving set of 3 years of data, and you'd break it down into, there were 57 different procedure groups in congenital heart surgery. That's one of the difficulties in congenital heart surgery. There's a huge number of different lesions that we treat and different procedures that we do. So trying to have group procedures together, you have to be clear and careful that you get things that you're comparing like with like. But it includes cardiac surgery and interventional cardiology. And it produces these sort of funnel plots, we call them, where the black line is the national mean, and that's where you'd like to be performing, and every center is a different dot, and you can see where they are performing on that line. But as long as you're above the green line, which is a 98% confidence interval, the feeling was that you could therefore demonstrate that you're operating within a sort of safe zone. And also you would get this your entire amalgamated practice. Every single case that you're doing, every case was risk adjusted, and again you could then be shown all the different centers in the UK along the x-axis there, and you'd want to be in the white zone or even higher up. If you're in the turquoise or the green zone at the top, you're overperforming what you would have been expected across your entire practice. So you're aiming to be above that, and you don't obviously want to be dropping into the grey or the black line. So it's a very easy visual display of how your entire program is performing, and you would be issued with an alert warning by the government, by the Ministry of Health, if you were outside the 97% confidence interval, and an alarm warning if you're over the 99% confidence interval. So that's part of regulation. But the other thing is, as I say, it's also there the idea is it's there to help you. And so all centers have this software provided for them where you can actually monitor your own performance. And it's called a VLAD chart, a variable life adjusted display. But basically every case you do, you go along the x-axis, and every time you have a survivor, the curve goes up. If you have a death in hospital, the curve goes down. So you want to be going above the line. So you always want to be trending above the line, and it's bound to bounce around a little bit, but you should always be aiming to go above the line. So you can see if you're having clusters of problems or whether your overall performance is heading in the right direction. But it's all risk adjusted. So if you were to have a very high risk case, very complex high risk case, and you were to have an operative or an in-hospital death, then the drop is relatively small. Whereas if you have a relatively low risk case and an inter-hospital death, then you get a bigger drop. And likewise with the degree that each one goes up. So you end up with this risk adjusted display. And the idea is you hope that over time, you see your practice, this sort of progression showing you're performing better than expected. And it kind of helps you keep track of things. You can do this real time and monitor how you're performing and be aware of where you're having clusters of problems and so forth. But certainly there's unintended consequences around this kind of reporting of data. Some of it, leads to bad behavior, can lead to people trying to game the system, understanding the software, or inevitably, one of the problems with surgeons is that we are by nature kind of competitive individuals. So as soon as you start generating data, people start to use it to try and generate lead tables and say, we're better than you, and so on. And so it does raise the questions of whether you should really sometimes maybe avoid absolute figures and rather you provide a standard and say, well, you are performing within the standard, and that's all you need to know. Nothing, nothing beyond that is necessary. But in the UK, it caused a lot of problems in terms of people becoming like a rivalry between centres and people not trusting people or not trusting other people's results. So for sure, it potentially has its problems, and that's why it has to be managed very sensitively and very professionally by the people who have control over the data. And so having independent and national bodies who control it seems to be by far the safest way of doing it. It's particularly difficult in the US with multiple healthcare providers, where money becomes an issue, and people potentially can use outcome data as leverage to say our practice is better than yours and attract more money into their system. So it really does have to be used incredibly sensitively, and you get these kind of the US news reports are famously out there, and every cardiac center in the US is fighting to be in the top rank in there, because it attracts more patients for them and it improves their position in the market, and it may not necessarily be in the best interests of the patients, and it may cause bad behavior amongst the surgeons, of course. But none of us can help it. It's in our nature to look at sort of scoring systems, and we're very happy that in the Newsweek report, Sick Kids has been ranked the #1 children's hospital in the world in 2022 and #2 in the world in 23 and 24, and that cardiac surgery and cardiology are one of the 6 key specialties they look at when they get those scoring systems. So we all like it when it's in our favor, of course. But yeah, and then what you do, how you then manage somebody if you go to all this effort and produce all this data. Well, what do you do if you are, because there will be a variability in outcomes. That's the truth of any system, right? Somebody's going to be underperforming, someone's going to be overperforming. So you get this kind of mixture, and if you want, you can rank all the programs in terms of their outcomes, and that's the sort of spectrum that you get. So understanding how to manage programs that aren't doing as well is a key part of using this data responsibly. Probably if you want public reporting to look good, it should have to be mandatory, so everybody's got to submit their data. You can't have a choice over it. It has to be risk adjusted, and I think it's very important that it becomes team-based outcomes. It's not individual surgeons, and this caused a lot of trouble in the UK, actually trying to publish individual surgeons' outcomes. It wasn't felt to be helpful, and that we recognize that really the outcomes reflect the performance of the whole team, and that you should report outcomes as a programmatic outcome and not as individual surgeons, because that actually empowers the individual surgeons to work for each other, because it's their investors' responsibility to make sure the whole team is performing well. But certainly using benchmark procedures and some degree of risk adjustment is very helpful. But then finally, really important that if it's going to be on a sort of public reporting process, that there are proper ways of communicating it to the public and using language to describe what the results mean, so that people don't misinterpret the data and take it the wrong way. But it has great benefits, I think, in many ways. It gives your public, your patients, trust in what you're doing, that you can demonstrate what you're doing in a sort of open and transparent way, as well as giving fantastic opportunities for research. You end up with these huge databases of activity, and also an opportunity for us as a profession to set standards which nobody needs to argue against, because they're there in black and white for you to see. One of the things we are all aware of, and I know I've talked to many of you, that this is the case in many specialties across surgery, is that, of course, immediately the data gets used for these age-old questions of the relationship between the volume of programs and outcomes. And there's been a lot of discussion around this, and many countries around the world have gone through this kind of issue of regionalization and centralization of services because of this sort of data, which shows pretty clearly that there's a very strong relationship between the volume of programs and the outcomes, particularly in the more complex and high-risk areas of what we do. But it's certainly in the US at the moment, it's causing huge kind of debate because of the financial implications in their healthcare system of trying to regionalize centers and trying to stop small centers from doing occasional practice. And there are these sort of pretty clear data for us in cardiac surgery that really, if your annual case volume is below even 300, there's a kind of inflection point in your outcomes, and that you really need to be of a certain volume to really be able to generate, have that team approach to generate the best outcomes. And the same here this is for neonatal surgery, where the highest risk is. And again, this rather messy graph is showing you that around about 60 neonatal cases per year is the inflection point. If you're doing less than that, you're probably not in the zone where you can get the best possible outcomes. So this data can be very helpful to drive quality improvement at a sort of national level to make sure that you're really delivering the service and the right size programs. So I'm going to finish off the last sort of 10 minutes or so, really just going back to some of the data, how we use it in sick kids. And we use more than just that STS data that I've shown you. And that, I mean, the trouble with cardiac surgery, the reason why it's often, I think, landed at the center of all this data reporting is that it's ideal for this sort of analysis. It's high risk, so it's got a very measurable mortality. And the nature of the surgery is that you can relate the mortality very much to the surgical performance. So people love that kind of fact that you can relate the outcomes to the quality of the surgery, but it puts you under a huge amount of scrutiny. But we all know that mortality is only a small part of what's important and what we do. And now we have all these various registries that are there in both intensive care and in cardiology as well as in surgery to help us benchmark what we're doing. So this is the Critical Care Consortium. So this gives us the same sort of outputs. Here, this is looking at the length of stay in ICU post-op. And again, it shows you where you are compared to the spread of all the means of pretty well all the hospitals across North America. So again, you want to see where you are in terms of your length of stay in an ICU. And if that moves over a period of time, you want to ask yourselves why that's happening. Again, it picked out key complications. You want to see what your complication rate is post-surgery compared to other centers. This is unplanned re-interventions, exactly the same sort of displays that you can learn from. And we're able to look at that data every year, and as a heart center, bring intensive care, cardiology, surgery together and look at areas where we're performing well and areas where we need to be performing better. These are our post-operative lengths of stay. And I think one of the things we've done very well at Sick Kids is that we managed to get patients through extremely fast, which of course is a whole team sort of process to achieve that. But of course, it starts with good quality surgery and good quality ICU and moving the patients through intensive care fast. But the stat categories, remember the complexity of the surgery. So the more complex the condition, generally the longer you're likely to stay in hospital. But you can see that across really all that range at Sick Kids, our hospital stays are really often a third of what's expected across all of North America. So we're really able to get the children out through the service quickly. Part of that is because we aim to extubate a lot of the patients in the operating room, which really for cardiac surgery was almost unheard of sort of 20 years ago. And nowadays, particularly in the older infants and older children, we aim to extubate the patients in the operating room to really progresses them through the whole hospital stay much more quickly. And you see the Sick Kids data on the top compared to the means across North America, and you can see how well Sick Kids does with the yellow bars compared to the national averages. And getting those patients through fast is a credit, to the anaesthetic team and the preoperative setup of the patients just as much as to the surgery itself. Heart transplantation, and Sick Kids, the biggest transplant centre for children in Canada. And again, we've got transplant registries which are international, where we can compare our outcomes against international means and be reassured that we're doing well. you see now that nowadays really the results have gradually improved over the years, but certainly now you can see that you really expect something like 70 to 75% of children with a heart transplant to still be alive and free of rejection at 15 years. But we do particularly well in the area of cardiomyopathy. Sick kids is the dotted red line, and our survival for children with cardiomyopathy is remarkably good. That helps us try to look into why that might be, and helpfully then disseminate that sort of information internationally to help bring all those results better around the world. And as you know, there were one real landmark paper was with the first ever ABO incompatible heart transplants were done here at sick kids. Adult congenital surgery is another thing we increasingly look at. Now, as I say, have more adults alive with congenital heart disease than children. And so the consequence of that is that we become the custodians of looking after those patients for life. And often they have residual lesions or new lesions as a result of their surgery in childhood. And now we're seeing adults with congenital heart disease in their 60s and 70s who we operate on at Toronto General with a whole team of specialists in adult congenital heart disease. And those are the sort of numbers of the cases we're doing, so close to 100 adult cases a year now, as well as the children that we operate on at sick kids across a whole variety of lesions. And again, this is a publication recently from us around showing that with a dedicated team of intensive care, of cardiac anesthesia, and the adult congenital cardiology and surgeons working together, we were able to really redefine the way we manage the patients with quite a dramatic improvement in the outcomes, with again, a mortality in those patients are now down to 1%. And finally, in terms of what we do in terms of performance, this is a really important thing of what we do at sick kids. Every Friday we have what we call performance rounds, and the whole heart centre attends these performance rounds. And the idea is a forum where the whole heart centre comes together, and we run through every cardiac case that we've done over a few minutes. And we've developed this software was developed by Christoph Haller, and is a nice visual display of the journey for every patient, and picks out the key events. Anybody in the heart unit can flag up an event, so it appears within the software, whether it's the OR nurse or the perfusionist or the intensivist can add things in. And we all sit together, and the idea is the concept of a kind of blameless but accountable practice. No one's trying to blame people, but you've got a sort of safe space where we're all together. It's confidential, but you can go through the cases and try and learn something. And developing this culture of being prepared to analyze what you're doing is a hugely important part, I think, of quality improvement. And done, and then we've had a lot of interest in this from other centers around the US who are interested in replicating it. And it's only possible if you've got a culture really of improvement. I'm conscious of the time, and I wonder, can we just move towards the very end slides? I think I haven't really got time to go through some of the research and innovation that's going on within the department. But the slides will be there online if you wanted to look at them. But I think the whole idea of us is that with that foundation of a strong clinical practice, everything else follows what you're doing. And we're able to be very productive as a team of sort of surgeon scientists, and that University of Toronto mantra of being a surgeon scientist. And that you can be a productive and useful clinician, still have an active research program, has been very much the mantra of how we've tried to run things at sick kids, and we've been very proud of what we've been able to achieve in terms of the research output of what we do, as well as the clinical practice, which I still believe is the foundation of everything that we do. So I want to, can you just get me to the last couple of slides? But it's been a great journey that I've had here over the last run through that. Yeah, I'll just run through. And so I say, but I should just end with a little thank you to everybody. We have a wonderful team of people. I can't possibly thank everybody. This was the American Association meeting this year that was held in Toronto, and we were able to assemble every surgeon who's worked as a staff surgeon here at Sick Kids since the 1970s. In the middle, the tallest of us all is George Trusler, who was the chief of surgery here in the 70s and just had his 98th birthday and had the Order of Ontario this year. Next to him is Bill Williams, who was the chief following him, and Glenn Van Arsdale, who I'm sure who followed Bill Williams, kneeling down in the front row together there with all our surgeons here in the team today. And that's the motley crew of who we are, the 5 surgeons here at Sick Kids. And I couldn't have wished for a better set of colleagues and a happier sort of working environment. And I say we're driven by this culture of a team, and that you only really succeed if all of you are rising together to drive better outcomes for us and for your patients. And I think so. Our philosophy really has very much been that high quality clinical outcomes are at the center of what we do, and using data to drive it, and to be able to be open and transparent about what you're doing, to be able to tell people what you're doing and reassure people is a hugely important part of data reporting. And I think the academic excellence comes along with that, and it's the surgeon scientist approach of University of Toronto and Sick Kids which has really brought us there. And that with it brings surgical innovation. And I think as a mentor and trying to bring the team together, investing in your trainees and in your junior staff is the key to really sustained good performance. And you really, I always feel you go into that sort of relationship with your junior colleagues is that you're trying to make them better than you when they come out of their kind of full training time. What's happening? But thank you, everybody. We love Toronto. You've been wonderful colleagues to work with, and professionally, I could not have wished for anything more. We're off, returning back to the UK next year, and we will go away with many happy memories of Toronto. We're proud to become Canadian citizens in January before we leave. But thank you, everybody, very much, and I hope you can go away and build your own practice and use data to make you stronger. Thank you very much.
Thank you very much, Dr. Barron. I think we have time for one question, Dr. Yao.
So David, thanks very much for a wonderful example of some of the principles of CQI and best practices that Robin herself was so passionate about during her career. And I want to congratulate you and thank you on behalf of the University Division for your leadership over this last 5 years and really bringing your team to unprecedented heights in terms of clinical excellence that has not been seen even in the long and storied history of this institution. So a quick question about basically how one factors risk tolerance for and innovation into a quality improvement scheme that oftentimes for many of us depends on standardization or optimization of care pathways, so that we sort of with new programs we pick cases carefully, we monitor it in real time as you talked about, but how much runway should an institution give a new program, like for in terms of cases or time, and how does one factor that into this?
Yes, that's a really, I think, really good question, really important question. And one of the risks, as we mentioned, in terms of this kind of reporting, is a risk aversion, and it's true, it can happen, but also potentially a risk to stifling innovation. People don't want to take the risk of a new procedure. So you certainly need, I think, you need the supportive institution. You need some sort of system of maybe proctorship, or an institutional program of what to do when you want to introduce a new procedure. So it's up to you, I think, a response as a surgeon to demonstrate, make a good case for it, demonstrate why you think there's value in it. You then want the institution to back you, but you do want to set out some sort of governance guidelines. So saying we're going to bring if it's appropriate, bring a proctor in who's experienced in it, who can supervise you and demonstrate that you're doing well and sort of benchmark you, but also say we'll do so many cases. This is what we're going to look at, and we're going to stop after 5 months, 6 months, a year, and review it and look to see how we're performing. And I think if you can at least put those sort of governance kind of system in place, then you can reassure people you're doing it responsibly, and that you're still able to do innovation. But I think you want the institution should be backing you. And again, if you've got the data to show how well you're doing, you say, look, we believe this is the right thing to do, and we want you to back us. Then hopefully, they will pick up the ball and come with you. But as in so many things, a lot of it depends on the strength of the surgeon, on the commitment to progress and to innovate. And there's certainly a risk, I think, that some of this data may put people off trying to innovate, and we must never let that happen.
Thanks so much, David and Sarah, for everything you've done for the university.
My question has to do with individual surgeon wellness. And just thinking about this intense scrutiny that is in real time as a young surgeon starting out, even though you may not be identified as the one who had this mortality, you're bringing down the team. And how do you do this? How do you support your young team members so they don't fall by the wayside?
And it's great. They're great questions, and they're the core of what we do. I think some of the things I alluded to of really having a team approach and investing that the outcomes of your most junior colleague are equally, if not more, your responsibility of the senior surgeons as it is for them. Because we've walked the path, we know what it feels like, and at least providing that sort of empathy and support is really important. So that sort of fundamental human thing of just phone a friend, of just saying, if you're ever in trouble, just call me. It's not a problem. That is a huge weight off your shoulders as a young surgeon. And to encourage people that there's nothing to be ashamed of in calling for help. We've all been there. Sami came and helped me in a case in the middle of the night last night, because I just knew having somebody sensible and professional as an ex-pair of eyes made my life much more simple and a better outcome for the patients. And if you can get that across to people, then I think that's the trick. But yeah, it's hard, and we all recognise those are the hard parts of surgery, and that particularly in this age where we feel terribly under scrutiny, all this data out there in the public. Not to mention that kind of competitive aspect that we all want to be better than everybody else, but somehow you've got to find a way of navigating it. And I think the way is a team of you working together and recognizing that their outcomes are important as yours, to you personally. So that's your trick. It's a difficult trick to manifest. Yeah.
If I can ask one very quick question, but when you're during the performance rounds, how do you dig into the root cause of rare events like mortality?
Well, yeah, it's you don't always have time to do it. It's certainly it's a very useful little point in time though, where even if you don't get to a solution, it's tripped something in your head about something that we could be doing better, or that you might want to come back to. You can't always say, and of course there are kind of two ends of the spectrum. One is where you're overly compliant and say, oh well, it was a difficult case. God, you did your best, well done, and you don't really learn anything. And the other end is where everybody's like fighting like cats with each other and trying to blame everybody for what they're doing. And so again, you've got to be able to manage that sort of behavior and try and find a path where you are genuinely constructive and say, look, we didn't do this well. I think we were wrong because we recognize we could have made the diagnosis better. We could have discussed it clearly beforehand. All these little things in the pathway for the patient, and trying to be able to be open and honest is the trick to it. And it's not always easy, and you don't always get to the solution. But at least if you're doing it, you've already got halfway there to recognize the value in trying to analyze it.
Thank you so much. And a fantastic lecture and excellent outcome.